Three, two, one. We are live now. Please.
Good evening, friends. Welcome to the PG track program of the Delhi CSI, and now we are entering into the 30th webinar of the this PG track program. It's been a great journey, and we have come up with new speakers every time and with wonderful topics. Some of them repetitive, so that you can have a different perspective from the different examiners. And today we are going to have a talk on the clinical approach to the cyanotic congenital heart disease. As you all know, that cyanotic congenital heart disease is a must-have case in the exam. And often it is difficult for all of us to interpret and design and define our right approach, that how should we diagnose and how should we clinically differentiate, that what is the right methodology and what is the right diagnosis in the case that we have got. So what examiners are actually assessing is not your diagnosis, but your approach and your clinical sense in that particular situation. And that is the reason today we have Dr. Saurabh Gupta, young dynamic pediatric cardiologist who is additional professor of cardiology from All India Institute of Medical Sciences. And along with me, I have Dr. Girish MP, who is professor of cardiology from JB Pant Hospital, and Dr. Neeraj Avasthi, who is again a pediatric cardiologist from Delhi. So it's such a great evening. What a great day, auspicious day of Dhanteras. And we were just joking that this is a Dhanteras of the Gyan of knowledge. And all those who have taken out time, I'm really thankful to you for taking out time on this evening, and enjoy this wonderful evening and have this wonderful session. In case you have questions and comments, please feel free to write them. As many questions you have, whatever your clarifications, please write them. We will ask Dr. Saurabh or discuss amongst ourselves and give you the right answers in the approach. And in case you miss out the lecture, don't worry, this lecture will be available on the channel PG Track CSI Delhi branch, which you can subscribe. And in case you want any further clarifications and questions or particular session, please write to us on our email. So over to you, Dr. Girish, to please start the session and invite Dr. Saurabh for the session.
Yeah, good evening. Good evening, everyone. And it's actually an honor to have one of my closest younger colleagues from All India Institute of Medical Sciences, who's a teacher par excellence and a very good academician as well as a good clinician, especially in pediatric cardiology. I hereby invite Dr. Saurabh Kumar to start his lecture.
Yeah, thank you, Dr. Girish. Thank you, Dr. Mohit, and for giving me this opportunity. Is my screen visible?
No, please share your screen.
Okay, Saurabh. Yeah, I'll share it
you
again.
Can do that.
I think I'll have to. So I hope
yeah, it's visible now.
So as Dr. Mohit said in the beginning, that cyanotic CHD is one of the cases, but I look the cases slightly differently, because I generally feel that if we approach a disease from our own perspective, then we learn more and probably we retain more. And I'll follow the same philosophy during my presentation. It may not be completely case-based, but yes, it will be in and around that. And I'll be happy to take questions after the presentation. So having said that, when I was given this topic by Dr. Mohit, I was confused as to, is this topic really relevant enough to, spend an evening, which is Deepavali weekend, with so many issues like Corona pandemic, AQI, cracker ban, and all other stuff going around. But then I realized that there is a lot of scope of understanding more about cyanotic congenital heart disease, because even today, it's not uncommon to encounter a patient who is completely unaware of their congenital heart disease, even in their, late 20s. And incidentally, just 2 days back, I got a call from Patiala that a girl who is 20 years was seeking visa application for going to Canada for higher studies. And during medical examination, she was found to have congenital heart disease. And not so good for the patient. Actually, she turned out to be a cyanotic congenital heart disease with severe Epstein's anomaly, with visible cyanosis, and possibly it was missed all throughout these 20 years. And that's why I think that it's quite relevant. And of course, it is relevant for the cardiologist, who are seeking training in cardiology. So with that background, I'll start by saying what is cyanosis. So cyanosis can be acrocyanosis when it is limited to extremities, and it indicates poor perfusion. It generally is not indicative of congenital heart disease because the saturation and the PaO2s are normal, and it's just because of the sluggish perfusion in that area. Now, the one which we are talking today is the central cyanosis, whereby we get cyanosis all over the body. It indicates serious circulatory and respiratory abnormality, and low saturation is mostly, but not always, because of low PaO2. And these exceptions are related to abnormal hemoglobin. And I'm sure that you are aware of methemoglobinemia and sulfonylurea. That's why this statement is written like this over here. Now, the third type is differential or the reverse differential cyanosis. It's a type of central cyanosis only, but here the saturations are different in the preductal and the postductal area. And if it is present, it indicates that the congenital cardiac malformation has PDA in its circuit. It may be the reversal across the PDA may be because of the high PVRI, or it may be because of aortic arch interruption or coarctation. Now, when we talk about congenital heart disease, before going to cyanotic congenital heart disease, let us see what is the classification. So hemodynamic classification, these patients may present with hypotension or shock. They may have cyanosis or heart failure. And today we will be discussing this group. Now, if we talk about persistent central cyanosis, I mean, these are various causes. I mean, of course, not all of them are relevant in a case. Depending upon the age, these things will differ. But today we will be discussing this part, circulation. And as I have given here, airway, breathing, circulation, or defective hemoglobin can be different causes of cyanosis at different age groups. And the importance of age cannot be overemphasized during any of such presentation when we are talking about cyanotic congenital heart disease without specifying the age. And so that remains individualized from case to case. Now, I always emphasize that cyanosis is not a great clinical tool, and I'll tell why. Because the detection of cyanosis depends upon the skin color, hemoglobin level, and its type. As you can see over here, if the patient has hemoglobin F, it means that when the patient is a neonate or a young infant, then hemoglobin F is more predominant. And because of the characteristics of the PaO2, the P50 and the oxygen dissociation curve, this patient will behave quite differently from a grown-up patient who has predominantly hemoglobin A. And as you can see, these oxygen dissociation curves are different, and this will reflect onto how easily or how difficult it will be to detect cyanosis in these patients for the similar degree of desaturation. Now, another important thing is the experience of the examiner. As you would have all noticed, that an experienced cardiologist, more so if they are trained to treat patients with congenital heart disease, they can even pick minimal cyanosis, while the others, even the gross cyanosis, may not be apparent. And that is one of the very, very important factors. And other factors like acidosis, alkalosis can also change. Now, looking at the hemoglobin level, and by the general rule where we think that cyanosis can be picked at 85%, as you will notice over here, if you were to pick cyanosis only at 85%, you will have to have 20 gram% of hemoglobin, because you need 3 gram% of deoxygenated hemoglobin to pick up cyanosis. And we all know that that is not true. As pediatric cardiologists, we pick even 88% or even 90% cyanosis as minimal or mild cyanosis. And that explains why it is so much important to keep in mind that the experience of the examiner is very important factor as far as the clinical detection of cyanosis goes. So if we take cyanosis, which is defined as bluish discoloration of mucosa and skin, as a lab test, then this is a test which has a very poor characteristics for being a screening tool, because it has very high false negativity, because not all of medical professionals or health professionals will be able to pick mild cyanosis. It will also have, but it has low false positivity. So as a result, if this is a tool, low sensitivity but high specificity, low negative predictive value, but high positive predictive value, meaning thereby if cyanosis is present, you can be assured that there is serious congenital heart disease underlying. But if you are not picking cyanosis, it does not rule out a significant heart disease. It also does not rule out a heart disease which has arterial desaturation. And that is why I always say arterial desaturation is not the same as cyanosis, and these two has to be kept differently, and that also emphasizes the importance of pulse oximetry. So all patients with suspected CHD should have pulse oximetry in right arm and one of the legs, because the right arm is the location which is before the duct and leg is the location which is after the duct, and this will help us in defining differential cyanosis. Pulse oximetry should also be always carried at rest and following exertion, because minimal degrees of desaturation cannot be picked at rest and it may become obvious following exertion. Now, so looking at the same table, I have replaced cyanosis with arterial desaturation, and throughout the presentation I'll follow this term arterial desaturation for the reasons I just explained. Now this is the group we are talking about here. As we have been trained throughout our medical profession, we cannot learn about clinical presentation until and unless we understand the pathophysiology. So I'll start from there. And arterial desaturation congenital heart diseases can be classified depending upon what is the pulmonary blood flow and what is the pulmonary artery pressure. So if it is low, then we are talking about tetralogy of Fallot or conditions similar to tetralogy of Fallot, which is commonly called as pathophysiology. In the same breath, sometimes we use ASD with severe PS, although it is slightly different from tetralogy, but for clinical and hemodynamic characteristics, they are clubbed together. The other group is increased pulmonary blood flow and high pulmonary artery pressure. The third group is no pulmonary stenosis with normal pulmonary artery pressure. And fourth one is pulmonary venous hypertension. As most of you must be aware that the last group is the one which is mostly seen in neonates and infants. And the other group are the ones which will be seen in grown-up children, adolescents, and adults. So we'll be focusing on these diseases much more than the last group. Now, to again understand the flow of blood in these conditions, now the blood which is coming from the systemic veins, which is systemic venous return, is actually destined to reach the lungs for oxygenation. And so this systemic venous return in absence of any intracardiac shunt is equal to systemic blood flow, is also equal to pulmonary blood flow. And since whole of the systemic venous return is getting oxygenated into the lungs, so it is effective in terms of generating oxygenation. So it is also equivalent to effective pulmonary blood flow. So in normal heart, pulmonary blood flow is equal to effective pulmonary blood flow is equal to systemic blood flow. And the saturation in pulmonary arteries is less than the saturation in femoral artery. Now, if we have a situation of intracardiac right to left shunt, as is the case in tetralogy of Fallot physiology, we will notice that the systemic venous return is equivalent to systemic blood flow, but there is some amount of blood which is going from right side to the left side, meaning thereby there is right to left shunt. So this right to left shunt, in addition to causing desaturation, it is also stealing away blood to the systemic circulation, thereby reducing the effective pulmonary blood flow. So effective pulmonary blood flow in this case is not equal to systemic venous return, but is actually systemic venous return minus right to left shunt. So as a result, pulmonary blood flow is equal to effective pulmonary blood flow, but both of these are less than the systemic blood flow. And that is why this condition is called decreased pulmonary blood flow. In absolute terms, pulmonary blood flow may or may not be reduced, but it is reduced in comparison to systemic blood flow, and that is why this condition is called as CCHD with reduced pulmonary blood flow. And as you will see, pulmonary arteries continue to receive this blood from systemic veins, the saturation in this pulmonary artery segment will still be lesser than the femoral artery segment. And the systemic blood flow will be inclusive of right to left shunt and the pulmonary venous return, which is coming from the lungs after oxygenation. Now, this is third physiology, admixture physiology. As the name suggests, here the blood from the left side is mixing with the right, and from the right side is mixing with the left. So the blue one is suggesting right to left shunt. So this is the amount of blood which is getting away from systemic venous return into the systemic circulation, and this amount of blood was supposed to reach to lungs for oxygenation, but instead it is going to the body. So the effective pulmonary blood flow is again less than the pulmonary blood flow. Similarly, the pulmonary blood flow is also receiving left to right shunt from pulmonary venous return, and therefore pulmonary blood flow is a composite of systemic venous return minus right to left shunt plus left to right shunt, and therefore the pulmonary blood flow is generally more than the effective pulmonary blood flow, depending upon whether or not the patient has pulmonary stenosis. This pulmonary blood flow will vary, and most of the time these patients will have higher pulmonary blood flow situation. And since there is admixture of left and right oxygenated and deoxygenated blood, saturation in the pulmonary artery and the femoral artery are both equal. And the effect of this on systemic blood flow are obvious. I don't need to emphasize it again. Now, coming to transposition physiology, here this is worst form of cyanotic congenital heart disease. Here, the blood which is coming from systemic veins and was destined to reach lungs for oxygenation is actually reaching the body. So there is 100% right to left shunt, and in absence of any communication within the heart, the effective pulmonary blood flow is 0, and that is incompatible with life. So there is some communication in the form of ASD, VSD or PDA. So if there is a communication, let's say at the level of ASD, this amount of blood from systemic venous return will reach to lungs, and this blue portion only is the one which is contributing to oxygenation. So effective pulmonary blood flow is only this anatomic right to left shunt, and therefore the pulmonary blood flow is much more than effective pulmonary blood flow. And that is why, since the effective pulmonary blood flow is much reduced in these patients have deep cyanosis despite having high pulmonary blood flow. And why I'm saying all this is because all of these are relevant when we are interpreting clinical findings in these patients. Now, when we see a patient with suspected arterial desaturation, we must differentiate it from respiratory causes, and most of the time it is possible, although it may be difficult in neonates and children. Initial assessment should include history, clinical examination, ECG and chest X-ray, and the aim of this evaluation should be hemodynamic classification. On most occasions, it's not possible to identify the exact cardiac lesion. However, there will be some clues which I'll be discussing later, which can tell us which is the more likely diagnosis in a given case. And more importantly, making an accurate diagnosis is seldom essential at the bedside. So clinical examination still holds true as far as the initial evaluation and management is concerned. Now, this is predominantly for those patients who are presenting early in life, or let us say in the situation when we are having academic discussion based on a case. So you have to have history in and around antenatal and perinatal period, any family history of congenital heart disease. Why this is important? Because congenital heart diseases are known to recur in families, and also the pattern of congenital heart disease which recurs in the family is also similar. So that makes this relevant. Feeding history, growth and nutrition, recurrent LRTI, this gives us clues about whether the pulmonary blood flow is high or low. Cyanosis, and I'll come to that little more detail in subsequent slides. And effort intolerance compared to peers. This will tell us about the degree of cyanosis in patients with predominant cyanosis, or also it may be reflective of heart failure. Now, before we go on to further classifying or clarifying about arterial desaturation, what are the characteristics? When you should think that the cyanosis which is related to in a patient is related to heart disease, or it may not be related. So generally, these patients have early onset cyanosis during infancy or childhood. It is persistent and there is predominant desaturation. So we are more likely to have visible cyanosis. It results from reduced effective pulmonary blood flow, as I have explained before. And most of the time, desaturation worsens with age in most lesions, except Epstein anomaly, where there can be bimodal presentation once they present in the neonatal period and later on once the patient is grown up. Desaturation is out of proportion to respiratory distress, and more importantly, desaturation does not normalize or have minor improvement with oxygen administration. Hyperoxy test written in books but is no longer used in the clinical practice. And as I have stated earlier, differential cyanosis indicate the presence of PDA in the circuit, although absence of differential cyanosis does not rule out PDA in the CHD circuit. Now, depending upon when the arterial desaturation has appeared, there are various conditions. For most of the candidates who are from cardiology background, this may not be absolutely necessary, but yes, this gives the clue that which diseases are possible if the history is coming out to be very clear. If the patient is presenting on day 1 to 7, most of the time we are dealing with severe malformations where there is either TGA type of serious right to left shunting issues, or there is severe reduction in pulmonary blood flow. Patients may present after first week when the PDA closes, and those conditions are like TGA, TOF, where the PDA dependent circulation is there. And there can be late onset cyanosis when this is manifestation of disease progression or increased demand of the baby, and typical conditions like pathophysiology and anomalies of systemic venous drainage. Now, as medical professionals, we all know age is not just a number. It tells much more than what the patient is having, because age determines what kind of diseases comes in our list of differential diagnosis whenever we are seeing a patient. So if we are seeing a grown-up patient, we must not make diagnosis of those conditions which are not common in adolescence and adulthood. And these are the conditions which should be considered whenever we are seeing any patient beyond childhood. So a common defects with expected survival in adulthood: TOF, pathophysiology, Eisenmenger syndrome, admixture lesions. Uncommon defects with expected survival like unobstructed TA-PVC, Epstein anomaly of tricuspid valve, and anomalies of systemic venous connection. Some of the uncommon defects may also have survival like single ventricle physiology, transposition of great arteries, especially if they are associated with PS. So till now, whatever I have said, the summary of that is, despite arterial that arterial desaturation is not same as cyanosis, and late detection is not equivalent to late onset of cyanosis, because as I emphasized earlier, clinical detection of cyanosis depends upon so many conditions, including experience of the examiner. So we can think how difficult it would be for the patient and their relatives to pick mild or, so to say, moderate cyanosis. And therefore, whenever we are finding a history of late onset cyanosis, we must think again and interpret it with pinch of salt, thinking that it may be actually late detection of cyanosis and not actually late onset of cyanosis, because these two are quite different things, and depending upon when is the onset, the conditions are quite different, which we have to consider. Now, despite arterial desaturation, Eisenmenger syndrome is not a typical cyanotic congenital heart disease, and the reasons of that we all know. Pathophysiology wise, pulmonary arteriovenous malformations are similar to cyanotic congenital heart disease, except that the shunt is extracardiac and the clinical findings are suggestive of absolutely normal heart. in cyanotic congenital heart disease, a normal clinical examination is generally not consistent with congenital heart disease. So, so the comprehensive clinical evaluation should include airway, breathing, and circulation, depending upon which setting we are seeing the case, pulse, saturation, BP in pre and postductal location, evidence of heart failure. This will be seen in conditions with increased pulmonary blood flow. And then we also must include abdomen for liver sidedness, because this will give us clues about whether we are dealing with the situation of situs solitus when the liver is on the right side, situs inversus when the liver is on the left side, or heterotaxis syndrome or situs ambiguous when the liver is in the midline. Dysmorphism on other congenital anomalies also suggests that there are chances that the patient is having congenital heart disease. In cardiovascular examination, we must include all the things. And when we are saying arterial desaturation, we must not put all our money on cardiac auscultation, because in some situation, particularly if the child is young or a neonate, cardiac auscultation may be completely normal, and it is not as useful as we think. As the child grows, as the child becomes adolescent or adult, the findings become more and more prominent, and they are more useful to us. Murmur is neither sensitive nor specific to rule out congenital heart disease, and that must be kept in mind. Murmur may or may not be there, but the cardiac sounds are better indicator of presence or absence of congenital heart disease. However, beyond childhood, normal auscultation practically rules out congenital heart disease, and that must be kept in mind whenever we are seeing a patient. Now, these are some of the clinical findings which, once they are present, indicate towards certain diagnosis. And although I'm not going stepwise into each part of the clinical evaluation, but as you can see over here, if we are finding a discordance between the abdominal situs and cardiac position, meaning thereby dextrocardia in situs solitus or levocardia in situs inversus, we must think of looping abnormalities like congenitally corrected transposition of great arteries. If the patient is having prominent A wave in JVP, which is generally a reflection of RVH or diastolic dysfunction of the RV, then we must think of any condition like TOF in adulthood, TOF with restrictive VSD, severe PS with or without small ASD, tricuspid atresia with restrictive ASD. Similarly, heart failure, if it is present in a child or an adolescent, we must think of TOF with restrictive VSD and other conditions which can tilt the balance towards high output failure like anemia, infective endocarditis, hypertension, aortic regurgitation into right ventricle, and other conditions which can cause heart failure. So in the setting of cyanotic congenital heart disease, if a patient presents with heart failure, is still in an adolescent and adult, tetralogy of Fallot remains the first diagnosis with associated lesions which can cause presence of heart failure. Other conditions which are associated with heart failure are AV valve regurgitation from AVSD, CCTGA or single ventricle physiology, and because of the chronic hypoxia, depending upon the severity of desaturation, these patients may also have ventricular dysfunction, and this also may be a reflection of natural history of the disease, such as in cases with CCTG and single ventricle. So all these things should come in mind if a patient with cyanosis is presenting with heart failure. Now, we all are aware that most of the conditions which cause cyanosis, most of the congenital heart disease which cause cyanosis have RV as the dominant ventricle, and therefore if you find left ventricular type of apex, then there are limited conditions which should be thought out as, like tricuspid atresia, single ventricle of LV morphology, and DORV with restrictive VSD. So practically, if RV type of apex is present, then we can rule out all these three. And if LV type is of apex is present, then we must include these three differentials in our differential diagnosis whenever we are seeing a case or whenever we are discussing a case in our academic discussion or during case presentation. Now coming to pulsations in the second left intercostal space, this indicate L-posed aorta, which is seen in the setting of CCTGA and is also seen in certain conditions with single ventricle physiology. Parasternal heave indicate that there is a difference, significant difference between the pressures on the right ventricular side and the left ventricular side, and there is intact ventricular septum. So a prominent parasternal heave actually practically makes a sizable VSD very less likely. Therefore, if you are finding parasternal heave, must consider conditions like severe PS with or without ASD, mostly with ASD if we are talking in terms of cyanosis. TOF will have parasternal heave only if VSD is restricted, and in situations like Eisenmenger syndrome when there is ASD and PDA, but it will not be there in cases with VSD, although mild degree of parasternal heave may be present even in patients with VSD. But if we are talking about grade 3 heave, we can practically rule out a sizable VSD. Loud S1 with multiple heart sounds, we know it's indicative of Epstein's anomaly. Prominent ejection systolic murmur with severe cyanosis, we should think conditions of TOF physiology other than TOF, and I will come to the explanation of that later, and that is related to the flow dynamics which we just discussed. PSM of AV valve regurgitation again indicate those conditions where it is common like CCTG and AVSD, and CSO murmur again indicate TOF with absent pulmonary valve. So this is a summary of what I said in last 2 slides. So there are many clinical indicators which helps us in putting our differentials one above the other and putting few other differentials lower down in our list, and that's how we can use these clinical findings to make or refine our list of differentials. Whether we like it or not, it may be confusing sometimes, and the confusion starts right from whether the patient has reduced pulmonary blood flow or whether the patient has increased pulmonary blood flow. So this is a generic table which tells when do you suspect that the patient has reduced pulmonary blood flow, and as you can see, history has very important role over here. If the patient is having signs of heart failure, which in a child would be indicated by interrupted feeding, sweating while feeding, failure to thrive, recurrent LRTI, then we are talking in terms of increased pulmonary blood flow. If the patient is typically giving history of squatting in cyanotic spells, then we are dealing more likely to deal with the reduced pulmonary blood flow type of situation. And some of the clinical findings, reduced pulmonary blood flow, since the less amount of blood is moving in and around the heart, there is no cardiomegaly. There is obstructed pulmonary outflow, so there is ejection systolic murmur, which is inversely related to cyanosis if it is typical TOF. These patients may also have continuous murmur depending upon where from the blood is coming, whether it is coming from PDA or it is coming from large aortopulmonary collateral. And generally, they will not have any flow murmur. They may or may not have any murmur from AV valve regurgitation, but flow murmurs are not generally, a finding in reduced pulmonary blood flow situation. While in this group with increased pulmonary blood flow, we'll find cardiomegaly, loud P2 indicative of increased pulmonary blood flow, and flow murmurs. And as I have indicated earlier, as the patient grows older, this group becomes less and less likely. So if we are dealing with the patient of more than 10 years of age, we should put more money on reduced pulmonary blood flow than on increased pulmonary blood flow, because the odds based on probability are towards reduced pulmonary blood flow. And the confusion is not limited to children, it even occurs in adulthood, and there the confusion mainly occurs between TOF and Eisenmenger syndrome. As I said earlier, it looks little counterintuitive. How can there be confusion between something which is like TOF with Eisenmenger syndrome? But we all know from our clinical experience that it happens sometimes. And these are the various findings which will differentiate TOF from Eisenmenger syndrome. Just to emphasize, S2 is very important in making this distinction. As we can see over here, in TOF type of situation, S2 is generally single because of inaudible P2. It is generally soft delayed P2 which is not audible because of significantly reduced pulmonary blood flow, and this reduction in audibility of P2 is also accentuated by malposition in conditions like congenitally corrected transposition of great arteries. On the other hand, in Eisenmenger syndrome, P2 is loud, and the conditions with VSD and PD may have single, while ASD will continue to have wide and fixed split. Again, a loud murmur, a prominent murmur practically rules out Eisenmenger syndrome, although a faint ejection systolic murmur may be present and EDM of pulmonary regurgitation may be present, more so if the patient is having PD Eisenmenger situation. So as Professor Tandon told all of us, and he has written in his book also, clinical examination, ECG and chest X-ray are tripods for clinical diagnosis of CHD. So no clinical examination is complete in a patient with suspected CHD if we haven't looked at the ECG and X-ray. Further, to add to that, the assessment of ECG and X-ray has to be in the clinical context. Out of clinical context, interpretation of ECG and X-ray can create more confusion and it does not resolve issues. So always first do clinical examination, make a set of differential before going on to ECG and X-ray. And before we analyze ECG and X-ray, like for any other thing, always ask for age of the patient and clinical status, whether or not the patient has heart failure, what is the extent or severity of arterial desaturation if the patient has arterial desaturation. And this is important. How? Because a cardiomegaly in a patient with cyanosis has a different meaning, and a patient with minimal or no cyanosis has a different meaning. In conditions with cyanotic congenital heart disease, if the patient has cardiomegaly, then we are talking about increased pulmonary blood flow situation like TGA physiology shown over here, admixture physiology like TAPVC, something shown here, and other conditions where there can be cardiomegaly because of cardiac lesions and dilatation of chamber without increased pulmonary blood flow like Epstein anomaly and PS with ASD, where there can be increased cardiothoracic ratio but without plethora. So whenever we are seeing a patient with congenital cyanotic heart disease, we must look at the heart size, whether or not there is cardiomegaly. Second, whenever there is cardiomegaly, we further differentiate whether the patient has reduced pulmonary blood flow, like in these two situations, or has increased pulmonary blood flow, like in these two situations. More importantly, the findings in X-ray are also age dependent. Although we keep talking about typical X-ray findings like here, figure of 8 appearance in supracardiac TAPVC, these findings are age dependent and will be seen only after few months of life and may not be apparent in neonates and younger children less than 3 months of age. Similarly, once the patient is grown up adult, we may not see the typical findings because there the X-ray picture is more suggestive of hemodynamic complications of the disease rather than the disease per se. So the typical findings are seen in possibly a relatively narrow age range of say young childhood to say maybe 20s, 30s, and beyond that it may not be the same as we may expect. Now in those patients where there is reduced pulmonary blood flow, we typically see no cardiomegaly and oligemia. And the fourth group, which is quite uncommon in grown-up children, we will see pulmonary venous hypertension, as in this case there is pulmonary venous hypertension because of obstructed TAPVC. And the conditions like anomalous systemic venous connection will practically have normal heart. So if you are finding nothing abnormal clinically as well as an X-ray, but arterial desaturation is there, always think of anomalous systemic venous connection before jumping on to pulmonary AV malformation, because both are possible, but the anomalies of systemic venous connection doesn't come to our attention quite often. and we end up doing other tests. And that is why I'm emphasizing again that with a normal cardiac examination and an X-ray which is nearly normal, we should always think of anomalies of system immune connection in addition to pulmonary AV malformation. Now, apart from cardiomegaly and pulmonary blood flow, a chest X-ray gives us very important clues about situs and cardiac position. As in this case, this is a patient of situs inversus, because we are seeing the gastric shadow on the left, on the right side. Liver is possibly on the left side, and the cardiac apex is on the left side. So we are having a situation of situs inversus with levocardia, and this is possibly L post aorta. In this X-ray, possibly we are not okay if we comment upon pulmonary flow, but it seems like it is reduced. So such a combination where there is discordance between situs and the cardiac position, as I highlighted earlier, we should be considering congenital CCTGA in these patients. So this is a summary of the X-ray findings, which I just said. So you see different things in the X-ray, and you define whether there is cardiomegaly or no cardiomegaly. And based on that, you further clarify whether the patient has which kind of disease is more likely. Now coming to ECG, an abnormal ECG indicates CHD. Consider getting right-sided leads more so if cardiac malposition is present in a patient based on the clinical evaluation. Now, ECG can give us clues about situs again. So this is in the setting of situs solitus with normally connected normally arranged right atrium on the right, left atrium on the left. And as you can see, P wave axis is in this direction. While if it is situs inversus and right atrium on the left side, we can see the P wave axis is on this side. And you will see the same findings are seen on ECG, where the P wave are inverted in AVR in the situation of situs solitus, while it will be upright in the situation of situs inversus. And this is the summary of how different cardiac positions will give us ECG. Now, this is not particularly important in diagnosing the heart disease specifically, but it tells us what is a likely situs. And then it also tells us about the ventricular arrangement by looking at the Q waves, and I'll come to that. Now, in terms of vector, normal frontal activation pattern is clockwise, and therefore we get Q waves in inferior leads, and this is the finding in normal and most of the congenital heart diseases. But if it is the other way around, like if it is counterclockwise with the Q wave in lead 1 and AVL, we should be thinking of tricuspid atresia, AV canal defect, inlet VSD, some of the DORVs, and Noonan syndrome. And to make things easy for us, most of these lesions are having left axis deviation. So if you're finding left axis deviation in the setting of congenital heart disease, and if there is counterclockwise loop, think of these conditions, and that again narrows down the possibilities. Now, this is the summary slide of ECG findings, by which we can, out of different tetralogy physiology, we can decipher whether it is more likely to be typical tetralogy or it is less likely to be typical tetralogy. So for example, over here, typical tetralogy, we keep saying early R2S transition from V1 to V2. And if the patient is having DORV, subaortic VSD, or for that matter TJVSDPS, then we are likely to have extreme right axis deviation. But this distinction is not foolproof, and there is large amount of overlap which is present. When there is ventricular inversion in terms of ventricular arrangement, RV lying onto the left side of left ventricle, then we have absent septal Q waves in V5, V6 with or without Q waves in V1 and V2, and this indicates CCTGA for all practical purposes. Monomorphic QRS suggests single ventricle. Polyphasic QRS with pre-excitation would indicate abstinence anomaly, especially if these patients have given us history of palpitation during our history taking. So these are some of the typical ECGs. So here, as you can see, there is no Q wave in the V5, V6, and instead there is a Q wave here. So it indicates CCTGA. Here there is left axis deviation and RV forces are almost not there. So we are in the situation of tricuspid atresia over here. So this is a summary of clinical examination. And since I was given to talk for 1 hour, I'll take another 5-10 minutes to complete a few slides on pathophysiology and related lesions. Will that be okay, Dr. Girish?
Perfect. Please go ahead. Please go
Okay. Okay. So now, if we don't talk about tetralogy of Fallot per se, we'll be doing injustice to the topic. So I thought that I'll make few slides on this. So pathophysiology, what is pathophysiology? Is pulmonary obstruction in presence of large VSD. And here the right to left shunt is occurring because of this combination. VSD is allowing that site for right to left shunt, and pulmonary obstruction is making that happen because there is increase in the right ventricular outflow resistance. So there is preferential flow from right ventricle to the left ventricle through a VSD, and it includes TOF, different TOF variants, and other lesions with pulmonary obstruction. So these are the 4 things, and the severity of pulmonary obstruction can vary from infundibular to valvular to supravalvular, and it can be as severe as to cause atresia. Intracardiac shunt can be at the level of VSD. Typically, ASD is not counted as pathophysiology, but as I highlighted earlier, for practical purposes, for clinical bedside teaching, we may consider both as same because presentation is quite similar to each other. Now, why these patients have late onset or increase in cyanosis during late childhood is because they continue to have progressive RVT obstruction, and this is one of the common questions which is being asked. That is why I thought that I'll dwell upon this little more. And this progressive obstruction occurs because of muscular hypertrophy and fibrosis, which sets in because of chronic hypoxia as well as shear stress across narrowed pulmonary outflow. Increased demand of a growing child also will lead to increase in cyanosis. And other reasons can be there like closure of PDA and stenosis in aortic pulmonary collaterals in the setting of pulmonary atresia. Now, as we all know, physical examination will show us central cyanosis. The cyanosis is quite variable. It may extend from minimal cyanosis, which may be missed by clinical examination. It can only be picked on pulse oximetry after physical exertion, and that again emphasizes why we should do pulse oximetry at rest as well as following exertion, and this may extend up to deep cyanosis, as we all know. And the cyanosis is determined by the severity of RVOT obstruction and the amount of pulmonary blood flow which is getting oxygenated, not the one which is already shunted. So we know lower is the effective pulmonary blood flow, more is the cyanosis. One more thing, last year the TOF pulmonary atresia may have better saturation than TOF with PS. It looks counterintuitive, but it occurs because if the alternative source of blood flow like the PDA or aortopulmonary blood flow is giving generous flow, then we may not have as severe cyanosis as we might be anticipating. So a deep cyanosis does not make either of the diagnosis more or less common. It may be pulmonary atresia as it may be pulmonary stenosis. These findings we know, this I have already highlighted. If you are finding heart failure in the setting of TOF, then we should be thinking of ventricular dysfunction, associated hypertension, anemia, aortic regurgitation, infective endocarditis, or VSD restriction. Clinical findings, generally the precordium is quiet, and since RV and LV are functioning as a single unit, RVSP is equal to LVSP, so there is no parasternal heave. Parasternal heave, if it is present, it will indicate restriction of VSD in the setting of pathophysiology. Normal JVP, except if VSD is restrictive or in adults where A wave may be slightly prominent. And these things I think is known. I'll not go in detail there. The murmur. So this murmur is typically ejection systolic murmur, and it is because of the turbulent flow across narrowed RVOT. Exact location is based on the site of obstruction, and the intensity depends upon the amount of blood flowing across RVOT. And this is important because I'll tell why it is important in few subsequent slides. Higher is the pulmonary blood flow, lesser is the cyanosis, louder is the murmur. So in typical TOF, if cyanosis is lesser, we are expecting louder murmur. So a pink TOF is expected to have louder murmur. A cyanosed TOF is expected to have fainter murmur. And this intensity of the murmur is also altered by viscosity of blood. Anemia increases the intensity while hyperviscosity reduces it. So if you are not hearing a murmur in a patient who is deeply cyanosed but is otherwise looking like TOF, you can still make a diagnosis of TOF with PS and explain absence of murmur merely by explaining it with increased viscosity of the blood without bringing in pulmonary atresia, because pulmonary atresia is less frequent compared to TOF with PS, and that would be the clinical utility of this argument which I have just explained to you. So this is just to show. So this is typically early transition from V1 to V2. We just thought, and this is the typical X-ray, and this is what we call pulmonary bay. Remember, pulmonary bay is not a normal finding. Pulmonary bay is found only in conditions when there is hypoplastic pulmonary artery. So when we are describing an X-ray, if it is showing normal pulmonary artery segment, it is always better to say normal pulmonary artery segment. We should not be saying absent pulmonary bay, because pulmonary bay is an abnormality. It is not normally expected. I hope I am making myself clear, because sometimes it is not taken well by the examiners when it is said like this. So the better statement may be PA segment is not well seen, pulmonary bay is present, cardiomegaly is absent, and there is pulmonary oligemia. So this is typical of Core and Sabot, which is typical of Tetralogy of Fallot. Now these are some of the variants. Tau with pulmonary atresia, the cyanosis would be earlier on onset. There will not be any ejection systolic murmur, but instead they may have continuous murmur. In addition to other findings on chest X-ray, they may have reticular shadows of collaterals and more dilatation of ascending aorta. So in the setting of tetralogy with no murmur, if you are finding significantly dilated ascending aorta, think of TOF with pulmonary atresia. Furthermore, if the aortic arch is also on the right side. And this is how, here you can see ascending aorta is dilated. Other one is absent pulmonary well. I think this is again seen more commonly in young children, not so common in adolescent and adults, but it has typical to and fro murmur, and the patient would have cardiomegaly with increased pulmonary blood flow and mild cyanosis compared to TOF patients. Others, like they may have absent branch pulmonary artery or one of the pulmonary artery coming from ascending aorta, or they may have restrictive VSD. Now a word about restrictive VSD. If they have restrictive VSD, they are likely to have less cyanosis, more likely to have RV dysfunction. They may have heart failure, and JVP may have prominent A wave, and parasternal heave may be present, which I highlighted even earlier. This is one example where LPA is from aorta and there is differential vascularity on the two sides, and this is sometimes called pleonemia. Now coming to non-TOF but TOF-like CHDs, why are they different? Because for the same degree of pulmonary obstruction and pulmonary blood flow, effective pulmonary blood flow is much lesser than TOF. And I think I explained it, but I'll just explain again. As you can see here, the effective pulmonary blood flow is this minus this, and it is only slightly reduced. While in admixture physiology or TGA physiology, the pulmonary blood flow is this amount plus this left to right shunt. This left to right shunt is fully oxygenated already because it is coming from pulmonary veins. So it is not contributing to oxygen. It is just going across the pulmonary valve and it is increasing the pulmonary blood flow. So in these conditions, pulmonary blood flow is much more than the effective pulmonary blood flow. For the same degree of effective pulmonary blood flow, typical TOF would have lesser pulmonary blood flow, and therefore they will have less intensity of murmur compared to other conditions. So other conditions would have earlier onset of cyanosis. Flow across RVOT is more than TOF. Therefore, murmur at RVOTO is louder than TOF, and cyanosis is also more for the same degree of pulmonary blood flow. A few specific lesions. So DORV, so if it is subaortic VSD with a PS, it behaves like TOF. If it is subpulmonic VSD, it behaves like TGA VSD PS. And if it is non-routable without PS, then it behaves like admixtures. So DORV practically can behave like almost like anything, and different ECG and other things we have already discussed. Again, the same thing here, TGA, relatively loud murmur and relatively narrow pedicle are the two things which can, differentiate in some cases and indicate that we may not be dealing with typical TOF, and instead we may be dealing with something like TJVSDPS. Now, CCTJVSDPS is a very, attractive case both for the examiner as well as for the presenter, because there are quite a few findings to be discussed. So L-post aorta is one of them, but mind you that this is not one of the most common clinical findings. So in absence of CCTJ also, in absence of L-post aorta also, you may consider CCTGA if there are other findings which are indicating. Another important thing which probably I missed out during ECG is presence of complete heart block. If it is present, we must be thinking of CCTGA. And ECG findings we have already mentioned. One of the important thing is that presence of Q wave in lead V1, V2 is very, very uncommon. It is more highlighted than it is really seen in the real world situation. Left axis deviation is another finding which is commonly seen, but it's generally not discussed. So that is another thing which can be kept in mind when you are explaining ECG of CCTGA. And if the patient is having CCTGA with VSD with PS, left axis deviation is not so common, and these patients may actually have right axis deviation. And this is the same X-ray, X-ray of CCTGA, and you can see in some of these cases there can be even a hump between here hump is there between RV and LV because the septum lies something like this in these patients. But this is a subtle finding. It's not so important. Even if it is missed, it doesn't make a huge difference in clinical presentation. And this one, I think I'll leave, except for saying that PS with intact septum may have prominent A wave, parasternal heave, pulmonary ejection click, and ESM has dynamic variation. Because there is no VSD, dynamic maneuvers are more useful in conditions whenever there is intact ventricular septum. And the ECG may have taller P wave compared to other conditions in TOF physiology. If there is hypoplastic RV in addition, then we have poor RV forces, and we may or may not have left axis deviation. And that again indicates that we are dealing with a situation where the RV is smaller. So to summarize, cyanosis is not the same as arterial desaturation. And for the reasons I explained earlier, I generally prefer, and I would request that I think we should move towards using the term desaturation, because using the term cyanosis gives us a false sense of security sometimes in even when we are missing significant arterial desaturation in some patients. Systematic approach permits hemodynamic classification of CHD, and some findings on examination, X-ray and ECG provide clues to a specific congenital heart disease and will help us in narrowing our differential diagnosis during our clinical bedside discussions. So these are some of the suggested readings which can be used to improve upon this understanding. Thank you so much. Happy Deepavali.
Thank you, Dr. Saurabh. Thank you so much for your wonderful talk, as usual. There are certain questions. Dr. Neeraj would also be joining me. So let us start from basics. One of the common things that is a dilemma that students also ask is that should we use the NYHA classification while quantifying the symptomatology in the pediatric cases, or should we use some other classification?
So above 6 years, yes, NYHA classification can be used. And since most of the examiners are more tuned to NYHA classification, that can be used. But this is not so applicable in cyanotic congenital heart disease situation, where the desaturation itself is, causing a lot of effort intolerance. So with that qualifier, we can use, there are certain other classifications which can be used for congenital heart disease situation. Dr. Neeraj, you want to add?
Yeah, actually, it's a nicely summarized presentation, I would say, Dr. Saurabh, and virtually covered all of the cyanotic heart disease. And I thank CSI and Dr. Mohit for the opportunity to interact at this hour, and wish everybody a happy Diwali and happy Dhanteras. I think you have to comprehensively surprise most of the things, and I agree with the NYHA. But we would take certain cyanotic questions which are asked very commonly in exam. No, the one is that although you have already told what to answer if it is asked that what is the saturation which is visible, when do you call cyanosis, and what is the cyanosis which is visible to a naked eye? You have summarized it, but how do we answer in an exam?
So practically speaking, I think saturation below 85% is generally picked by somebody who is MD, or who has seen some cases. More than 85% will be picked only by those who are experienced in cardiology, I would say. So I don't want to give a number, but 85 is a reasonable estimate where I would draw my lines.
So if in as an exam, I may summarize that we should say that cyanosis is generally visible whenever the amount of hemoglobin, as you have said, desaturated hemoglobin is more than 3 gram%, and generally 85% is visible to the naked eye.
Yes, actually, if I can make little clarification here, actually this 3 gram% comes from arterial level deoxyhemoglobin, and what we are seeing is capillary level deoxygenation. So that is why there is discordance between this 3%, 3 gram% calculation and what we are. So they are not equal. So when we are saying clinical detection of cyanosis, we are more talking in terms of saturation. So I think that is more, 85% is probably a more qualified answer. For theoretical purposes, yes, 3 gram%.
Another most common question is when murmur is out of proportion to degree of cyanosis. I mean, murmur is out of proportion to degree of cyanosis.
Saurabh answered that actually. So
yeah, so I answered. So the murmur, the determinants of murmur are: one, what is the flow across that narrowed orifice? Number two, what is the viscosity of the blood? Third, what is the thickness of the chest? And what is the experience of the examiner? Now let's leave the experience of the examiner and the thickness of the chest. Viscosity and anemia is obvious. If there is anemia, murmur will be louder. Apart from that, if the pulmonary blood flow is more, we'll have a louder murmur. So in all conditions which are like TOF but not TOF, pulmonary blood flow is more, so they have louder murmur. So if you are having a deeply cyanosed patient but a prominent murmur, consider non-type of TOF physiology situations higher up in the differentials.
Dr. Saurabh, one of the questions that we discussed last time was, and examiners are always fond of asking, is the early transition controversy. Dr. Saxena had nicely summarized that when she asked the same question to Dr. Tandon, he said that there is no still clear, dictum for that. But still examiners want an answer. So would you like to just take up this, or what should be the students saying? Because examiners always ask this question, and so they need at least a probable answer. Yes.
So basically, as you rightly said, and I think nobody has gone into the background pathogenesis of how these vectors are changing. But the common notion among trained clinicians or those who are in the position of taking exams is that since there is no VSD, we are getting reflection of the posterior wall, and that is why the complexes in the anterior precordial leads are taller. So like V1. So something like if you have changes in the say posterior wall MI, you get, or in conditions like Duchenne's muscular dystrophy, where we have tall R waves in V1, V2. Similarly here, since there is no VSD, we are getting more reflection of the posterior wall. And that is why we are having taller R wave in V4R or V1, and then it suddenly switches to S wave in V2.
So I totally agree. I mean, this is what the answer should be in exam, because most of us, we have a lot of exam going students who are there. So as a reflection of the, because of the large VSD, it is getting reflected. So we are getting this. And what if we don't get a early transition in a normal ECG? This is, we have presented a case of TOF and we are given an ECG. It's a classical TOF, and we do not get the early transition. So the answer,
so I would say that so I would say that it is still doesn't make it make TOF less likely. I will still keep TOF as my first differential if everything is going in that direction.
Yeah, so we should always keep, even if we don't get early transition, we should always keep a diagnosis of TOF. Yes, we should have a V4R as a right side lead, which might be helpful in this particular diagnosis. Is that okay, Doctor? Sorry if I may.
Yeah. So unfortunately, all these things have come from the era when we did not have, huge experience and a lot of data sets. So in contemporary practice, if we use the similar arguments, we'll be looking at what is the sensitivity of each of these, signs, which are ECG signs. And we may find that these are not as sensitive as we are always thinking. So that we have to always keep in mind. As I said, for CCTGA, septal Q waves in V1, V2 is so much highlighted, while it is not so common. Left axis deviation is much more common than septal Q wave in V1, V2. So that is why it is always important to read the ECG and X-ray in the clinical context, and it is more important to see the company it keeps rather than looking at only one or two signs.
And then Dr. Saurabh, there's one thing that we need to make clear to residents is that the controversy of something what we call as a mild TOF or a pink TOF. So pink TOF is is a term which is often used by many institutions, but often ignored or very seriously or offended term by many institutions. So TOF by definition is always severe. TOF by definition is always severe, as the book says. So what is your take? Should the person be using it as a pink TOF? Pink TOF is probably just a reflection of the pulmonary blood flow which is occurring, which could be due to collaterals or something. So does it make TOF more mild if the examiner asks, or should we say, what should be the person saying? And second, you said that TOF obstruction level, classical TOF is always described at the infundibular level. All describe infundibular stenosis as mandatory, and as you highlighted that it could be at any 4 of the levels. So if the patient is having a plain valvular stenosis along with all the other features, would you call it as a TOF?
Yeah. So first question about the severity of TOF. So when this question comes, we are actually mixing two issues together. TOF is an anatomic diagnosis, and based on that anatomic interpretation, it is always severe. In hemodynamic and clinical terms, when we look at the saturation wise, then we may say pink TOF as mild because it is causing mild desaturation or no desaturation. But we cannot mix these two things together.
That's a very perfect and new, actually the very right way of putting it. So one must understand that TOF by anatomically it may be severe, but its clinical manifestation may be a mild manifestation, not producing that saturation.
Yes,
it makes it called as a pink TOF, but that doesn't mean that it is less severe.
Agree to Dr. Saurabh. TOF is actually an anatomical diagnosis where is an anterior superior malalignment of the septum leading to VSD and PS. The degree of pulmonary blood flow may vary, and so the clinical manifestation also. So,
now,
totally agree.
Regarding the second question about if it is only valvular, so when we talk about typical TOF, yes, if we see older textbooks, say from surgery like Kirkland and all, they say up to maybe 5% of cases may have only valvular obstruction. So in those cases, findings would be different. But since that is not the common garden variety of TOF, we generally don't discuss about those findings. And in those cases, I mean, we have seen a few cases where we could even hear a click in the setting of TOF. So, but that is a less common situation, and for exam situation and academic discussion, maybe it may not be discussed that way.
Anemia and TOF, Dr. Saurabh, is another very commonly asked questions, and it's practical, simple management. So, and the classical, old, traditional, and fancy equations or the formulas that have been used. So, what would be your take in the present era if a student is and a fellow is asked about this question?
So, I think if I pose this question, differently, then there are 2-3 questions. One is, what hemoglobin level is appropriate for saturation?
Yeah.
Second, how do you diagnose iron deficiency in the setting of cyanotic congenital heart disease? Third, to whom you will give iron, to whom you may not give iron. I think these are the 3 questions which are relevant. So first thing is that there are no, I mean, there is no clarity as such, but contemporary understanding is that for iron deficiency, to prove or disprove, we should do ferritin levels. If the ferritin levels are low, we say that there is iron deficiency. The relationship with the saturation is not so robust as we always think. So if you want to define iron deficiency, do ferritin levels in addition to MCV, MCHC, and MCHC is probably better than other indicators. So if MCHC is less than 32, with ferritin which is low, we are talking in terms of iron deficiency. Now the next question is whether we should give iron to all of them. If a patient is deeply cyanosed, do we harm by giving iron? That is one of the relevant questions which comes to anybody's mind. So I actually read through this, and there are few papers which came up in late 90s where they looked at the concerns people have is, since there is polycythemia, there is hyperviscosity. Once you give iron, you are further increasing hyperviscosity, and you are risking more of stroke and thrombosis in these patients, and that is the concern people are having. But the studies have not shown any adverse increase in hyperviscosity with iron. Rather, if you give iron, your RBCs may be of more uniform size, they may have reduced sticking, and it is not just the amount of hemoglobin. Iron has multiple other changes on the RBC surface which makes it less sticky. So I personally prefer to give iron to all of them in not therapeutic range but supplemental range.
So there is no particular hemoglobin level or a formula or something to calculate like traditionally they have prescribed. They are not no more validated or something. That should be the right way.
I think so. What
MCHC
we follow
and the
is
ferritin, MCHC and the ferritin.
We follow anything less than 14 gram percent is not acceptable in the setting if somebody is having desaturation. But what is the upper level, or if somebody is having 15 milligram, do we say this is iron deficiency? I don't think we can be clear on that. So what less than 14.
What levels of iron become worrisome? Sorry, of hemoglobin become worrisome? When do you try to bleed a patient?
So one is if the patient is symptomatic for hyperviscosity.
Hyperviscosity. Yeah.
Second, if the patient is not symptomatic, all our effort should be to improve the hydration rather than thinking of doing exchange transfusion, because exchange transfusion, in addition to removing blood, is also removing the iron pool and maybe risking the patient. And there are episodes of stroke after phlebotomy in some patients. So it is wiser to further clarify whether the symptoms are there or not, whether these symptoms also may be a manifestation of iron deficiency, because symptoms are quite similar to each other. So it may be worthwhile to give them good amount of hydration and supplemental iron and see if the symptoms improve. If it doesn't improve, then think of giving IV hydration, and then the third step would be phlebotomy, and that also should be exchanged with a normotonic fluid.
Okay, and Dr. Saurabh, one of the residents, Dr. Rahul Walekar, is asking that how do you describe a typical episode of cyanotic spell? Number one in exam, and second, suck rest suck cycle.
So typical cyanotic spell. So any episode of incessant crying, rapid breathing, which is associated with visibly increased cyanosis, is cyanotic spell. Inconsolable cry, for pediatricians would understand what does it mean, inconsolable. Otherwise, if the child is not settling down with the usual maneuvers, is associated with tachypnea and is having worsening cyanosis, is a cyanotic spell. Now coming to suck rest suck cycle, again this is a common knowledge for those who are trained pediatricians. Suck rest suck cycle is something like dyspnea on exertion. So this is a dyspnea on exertion equivalent in a neonate or an infant, because for the neonate and infant, that is the activity. So when they are feeding, they are not able to feed in in one go. So when we assess feeding of a child, we look at 2-3 parameters. How much time does the child take to feed? Whether the child is hungry after one adequate feeding. So if the child remains hungry after what appears to be a good feeding by the mother, that is also an indicator that child did not feed well. If the child is taking, say, more than 10-15 minutes, which is the usual for a feeding cycle, it is taking 25 minutes, then again it is indicative that feeding was ineffective. And suck rest suck means child is sucking for lesser than the duration what the child should suck, and then taking rest in between, and then again sucking. So it's like equivalent of dyspnea and exertion.
That is fantastic, Dr. Saurabh. It's a great talk and even nice discussion. Lastly, I would ask you that do you have any specific recommended reads for these students, any particular articles that you would like to suggest so that they can get on the job right away? So any particular thing, because there's so much to read and so many things to cover. Some of the things that students should be focusing to strengthen their basics and have all the exam related and the practical knowledge before we end this session.
Yeah, so I think as far as the examination goes, from the examiners which are generally taking exams, I would still think that Tandon's book of bedside clinical diagnosis and second Parloff still remains quite relevant. And to be very honest, my approach is generally directly not clinical. So I am slightly, I take a slightly different course and then come to clinical. So I mean, I have also written few articles, but they are all towards pathophysiology and then clinical. So if somebody is interested, they can read that. But I will recommend those two, one book by Dr. Tandon and Parloff.
Terrific. So it's so nice. And in case any one of you wants any particular article written by Dr. Saurabh, I would request him to mail it to me and we will share those articles, or I will share Dr. Saurabh's email. You can get in touch with him directly. Dr. Saurabh, it's been great to hear you, a treat to hear you as always. You've been so kind and so gentle. Every time we request you, on one request, your answer is always yes. And thank you so much for taking out time. We have 200 plus residents who have joined us today. We started with only 45 and within minutes they have crossed more than 200, and we know that this lecture will be available on YouTube, so you can download and click the slides. There is no problem. You can use them for your exam. And Dr. Neeraj is always a great help. He's giving his great inputs. He has been examiner for DNB cardiology exams also. So thank you so much, Dr. Saurabh, Dr. Neeraj, for joining us. Thank you, Intas, for providing this platform. And friends, wish you a very happy, safe, and a wonderful Diwali. And I believe that we all kindle the candle of hope in our minds, and we also remove the fear and the darkness in our minds and the panic that we all are facing. And that is what is most important to celebrate Diwali in its truest sense. And next week, we'll come again with a new topic and with another speaker only for you, PG Track Delhi CSI branch. Thank you and good evening and have a great time. Thank you so much, Dr. Saurabh.
Thank you, Dr. Mohit. Thank you, everyone else. Thank you, Dr. Neeraj. And thank you, everybody who came to listen, because we all know that Diwali weekend is something very special for all of us. So thank you, everybody.
Thank you. Okay.
Thank you. Thank you.